fine. I'll leave it to you. You start. You're the tech expert here. And old geezer.
Okay, so we'll yeah, it'll be good if you can all can mute yourselves, or we may have to mute you otherwise. I'm sorry. Yeah, so let's. Hi, I'm Pavan. So I'm sure most of you know me. We've met, and some of you I know very, very well. So we will speak about introducing implant dentistry into your practice. So implant dentistry, as you all know, in the past 20 years has really grown a lot, maybe 15 to 20 years. And we all know that if it's practiced well, if done well, then it is a very profitable thing to obviously introduce implant dentistry to your practice. But if things go wrong, then you do end up losing a lot of time and money to fix it. So you could introduce implant dentistry to your practice in one of many ways. So one is you could get involved with the surgical and the restorative aspects of implant dentistry. So that, I mean, both conventional way and digitally. Or if your interest is just surgical, then you could just do the surgery and get someone else to restore it for you. Or where I see more people do restore, and they get people to place implants for them. So these are the three options. Fourth really isn't an option, because if you're getting into implant dentistry, I think you should start doing it. So let's start off with this very first case. So this was about 13, 14 years ago. The reason I put this slide here is because we did this the conventional way. A very, very simple case for someone who wants to just restore implants. The implant was in the premolar area. You take a conventional impression, you get a stock abutment, shave it down. Obviously, the technician does it for you. And then we finished it off with a porcelain bonded to metal crown. So you could just do this, okay? That's the easiest part, basically. Or you could even do this. It's the same patient who had external resorption. So I carried out the extraction, placed the implant. We had obviously recorded that the biotype wasn't great, so I did a pedicle flap there. And then we finished it off about 14 years ago. Okay, so you could do the entire three parts. That's the two parts, surgical as well as the restorative aspect, or either or both. Okay. So what is the most important thing in implant dentistry? You've all heard this famous quote from Benjamin Franklin. It says, if you fail to plan, you plan to fail. So that is so true for implants, and especially when you do for large cases or immediate loading and all that. So we will speak through various options, various different ways of doing things. Obviously, 30 minutes or an hour isn't enough for us to teach implant dentistry. So we will kind of show you or lay the roadmap for you to acquire each of these skills which I showed today. Okay, so the two most important bit of kit you need is our loops and a full frame or a 3/4 frame camera. So I seriously think these are the two things which really change the way I practice dentistry. So if you haven't done that already, please do. Okay. So study models are very, very important. The past 5-6 years, I've not taken a single impression or a study model. I always can. You can look at things in 360 degrees, and obviously you can identify deficiencies in pink aesthetics, white aesthetics, and various other things, as you can see there, wear facets, chipped porcelain crown, and you can really, it's like having the patient right next to you, which you can't see in models, obviously. So this is definitely the way forward, I think. And then you've obviously got to plan the entire smile to make the smile fit into the window perfectly. Okay, so you've got to plan that as well. You can, the previous one I just showed was like a pen and paper smile design, which we used to do in the past. Now we have advanced planning softwares. So I've been using this for a few years. This is a 2D planning software from 3Shape. This is 3D from Exocad. So when you move teeth on the left-hand side, your teeth move on the right, and then it can be exported and milled straight away. So you can see how your newly designed bridge or crowns fit into the patient's mouth perfectly. These are face scans. I really get excited with face scans only because you can, the previous 3D design which I showed you is a flat photograph, it's a 2D. You can move teeth and models inside, but you can't turn the face itself. Whereas with face scans, you can do that. So the downside of face scans is obviously the ones which scan really well are very, very expensive. So what I tend to use is a very basic app, and that does the job for me. And then I tend to put that in the approximately right place in the articulator, and then we work on that way. But with these things, you definitely can't go for a definitive restoration straight away. You've got to have a PMMA restoration, make changes, transfer data to the lab, and correct it. Okay. So 3D interactive planning is very, very, very important. And this has grown a lot since I started about 15 years ago. So here, what we do is obviously place the implant, look and note down the defects and the deficiencies and all that. This white thing is your wax-up crown here, and the little thing sticking out in orange is the abutment. So in this case, I chose a conical connection. Okay, so no cement, no screws. And then we meshed up the anatomy. So what they call anatomy in Europe is all your teeth, basically. So we meshed up all your teeth with the wax-up, and the mesh can be rechecked multiple ways to make sure things are accurate. Then we design the surgical guide. Now, most stop there at that stage, okay? But what we do is connect an abutment, sorry, a scan body onto the planned implant, and we transfer it onto Exocad, okay? And we mill the final crown, or even, a temporary crown and a final abutment straight away. So I loaded this case that way, and then when I tapped the PMMA crown after 12 weeks, when I tapped it out, you can see a little bit of composite or PMMA chip there. It was brilliant. You can see there's absolutely no inflammation there, and not even a tiny bit of plaque. And we remove it, and then we fit the definitive crown in. So these crowns, I know there are shortcomings, there are drawbacks there, because these are milled, machine milled. These are not layered at all. We have just put a bit of white specks and glazed it. That's it, really. So, and the X-ray looks like this. So for those of you who don't have access to digital technology, can you not do it the conventional way? Of course you can. It just takes a little bit longer. And this is my case from 2011 or 12, I think. So a person with a fractured central incisor. So we moved on to like the picture on the right. The reason I put a black and white picture there is because you'll be able to appreciate fine detail, and especially when it comes to characterization. So in this case, we extracted the tooth, placed the implant. We used biomaterials just to bring the soft tissues down. Again, a technique taught to me by Ashok, and he's done it for a number of years. And then we used a rochette to support the soft tissues, and then a balanced posterior abutment by Dentsply, and then we finished it off. So the reason I put a black and white picture here is to see how we have characterized. So obviously with experience, and if you spend a little bit longer, you can definitely improve on it. And we will teach you how to do it. Okay. So this is what I do in my practice. So pretty much 99.9% is digital. We don't take impressions. I don't print models either, even for full arch cases, as you can see, the one on the left-hand side. I don't print models at all. Okay. So that way we've done about 5,000-6,000 complete treatments, including restorative. I'm not saying just implants, but without printing or gypsum models, you can imagine the much lesser impact we have on Mother Earth. So let's move on to different aspects of digital dentistry. So you can introduce intraoral scanners into your practice. If you do this, you obviously scan and then use a third-party lab to do it. If you want to take it a stage higher, you can 3D print in your practice, which we do quite a lot. And all these models are just for orthodontics or Invisalign type things, clear aligners. And then I use a 5-axis milling machine. So you will have access to this video later, so you can have a look at this at any point. Okay, so that's the general dentistry part. So all those bits can be implemented into your practice to generate better income and to provide better service to your patients. Okay, and as a part of the course we are talking about, we will make sure that you're competent in all those. So the two most important things, as you all agree with me, is to practice successful implant dentistry is surgical skills and prosthodontic knowledge. So I've seen people who are excellent at both. I've seen people who are good at one, who are not so good at the other. So they need to identify that and improve on it. Okay. So this is a very short example, because I'm just quickly flipping through, because I'm just trying to give you an idea of what can be done to develop your practice. Okay. So this patient lost her upper left 5 due to a vertical fracture, and she was referred by a dentist from East London. She is a producer for the BBC, and she really wanted an immediate restoration there. Okay. So I didn't go guided there, only because.
There you go.
Let me just mute. Yeah. So the reason I didn't go guided there was because I've done a little sinus tap there, and I've used a lot of condensers. As you can see, in 10 weeks, the bone wasn't kind of dense enough. And then I placed the implant. And the reason I put this case in here is because lots of you who don't have access to these advanced CAD softwares can do it this way. You can just scan the abutment itself in place and then make a crown with a 2-axis or a 3-axis milling machine. But in this case, what I did was, these are scan bodies which fit on top of the abutments. It's called Conical Direct Connect by Sweden and Martina. So this doesn't go into the implant. It just fits on top of the abutment. And then we transfer it off to the lab. And we mesh it up with ExoCAD. We have worked a lot with this particular company to provide us with various scan bodies and STL files to make sure that we carry out the entire workflow digitally. So that is a PMMA crown, a temporary, and I just tapped it in. No cement, no screws, and a perfectly happy patient. So the same thing can be taken up a level as you develop your surgical skills. So this is guided and immediately loaded. So I went completely guided with this lady. she was an 80-year-old, and she wanted teeth all of a sudden, and she wanted it really, really soon. She definitely couldn't wait. So we thought, is it possible? Can we do an immediate? And did all the planning, and we decided, yes, we can. So we extracted all of our incisors. I kept the canines to support the guide, and then I took the canine out towards the end. I placed 5 or 6 implants on the upper, and we restored her upper jaw all on the same day. Okay. So this was another case. The reason I'm showing you non-guided and delayed loading. So this case is again pretty much a full arch from about 10 years ago. The reason I'm showing you this is because I don't want you to be put off if you don't have access to digital equipment. You can slowly ease into it, but you can do these things conventionally as well. Okay, takes a little bit longer, but you can do it. So first thing is stabilization, which I really, really think is very important. So you really need to brush up your general dental practice skills, your restorative skills. And then this is just a delayed protocol I used there and finished it off with about 7 implants there, I think. Okay, so this was the patient I showed you earlier, where I did a 2D smile design, and then we ended up with a fairly decent result again. So the reason I'm just showing you clips is these are all the possibilities, and how to do it obviously takes a very long time and a lot of practice, and it needs a lot of skill development. So we can kind of guide you and help you through the process. So most of you have probably heard of impressions at first stage. Okay, again, Ashok started doing that about 30 years ago. Okay, and I do that digitally. I've done this for about 5-6 years. So the advantage here is I use biomaterials here, as you can see defects on the picture on the left. So when I use a lot of biomaterials and cover it up, and if the primary stability isn't great, I tend not to load. So I took a scan, carried out the GBR, and when we go back a few months later, 3 months later, we just place a small little incision, expose the implant, and put the definitive abutment straight away. You're not taking another impression, and the patient's not waiting another 2 or 3 weeks. So these are small little techniques and tweaks we can carry out to make things easier for patients. Okay, so I call that additional skills, protocols, and techniques. So another thing, the reason I've put these 2 photos here is the one on the left is for people who don't have access to scan bodies or advanced design softwares. Scan bodies are easy to get, but if you don't have Exocad or 3Shape lab softwares, it gets very, very hard to design implant level restorations, implant supported restorations. Whereas the one on the left, if you have a surgical guide and if you place the implants fairly parallel, or even without a guide, if you're very competent and you place implants perfectly parallel to each other, you can scan the abutments and mill a temporary prosthesis with your 2 or a 3 unit milling machine. Okay, so this is the same patient. I just thought I'll show you quickly, because this was loaded on the day. Extracted these 4 incisors. The right side was missing already, and we loaded it on those 4 implants. Okay, and the other skills you need to develop as you go on is connective tissue grafting. We call it periodontal plastic surgery. Very, very, very important, because I really, really think aesthetics is very difficult, and you've got to somehow learn to manage it. And when things go wrong, you can pull back and rescue yourself if you have these skills. So connective tissue grafts or free gingival grafts or pedicle flaps, all these are very, very, very important. So we will be talking about that in greater depth in our future meetings. So these The reason I put this picture is the case I showed you earlier. So you can see 3 temporaries on the left-hand side. I removed this full arch or 7-unit temporary just to show you how clean it looks with conical connection. There's not a bit of cement. Screw stings when you remove screw retain prosthesis. But this is beautiful, and this was just 12 weeks after I loaded it. Okay. So we can use stock abutments like the case I showed earlier, or you can alter tie bases. Tie bases not great in aesthetic areas because they're bulky, and zirconia goes on top of that as well. But in this particular case, we had a lot of room to play around with. In the premolar molar areas, you can use that where aesthetics is not of prime concern. So as you can see here, I've milled a zirconia abutment connected on top of the tie base, and it's connected onto the implant. Atlantis. I've used Atlantis for about 6-7 years before I had my own, about 8-9 years, I think. 2013, I started using them regularly. They've been a big part of most of the work I've carried out. The advantage with Atlantis is they're very, very accurate, very trustworthy, but there is a learning curve. So we will, as we go on, we will teach you how to do that as well. Okay, how to use a third-party milling milling lab or a massive unit like Atlantis. How to use it and how to incorporate it into your practice. Okay. And if you take it a level further, and this is what I do, you can mill your own abutments. So we have 2 milling machines. So in case I've just taken a scan, implant level after I've placed, or I start doubting the guide. Has the guide moved? Has the implant gone exactly where it's meant to go? Or has it shifted 0.5 millimeter here or there, 2 or 3 degrees here or there? So then you take an implant level impression with a scan body going into the implant. I get one of our milling machines to start milling the abutment. The other one mills the crown. In about 45 minutes, we have both, okay? And about 20 minutes of designing. But most of the times we have a pre-operative waxer, okay, which is saved digitally. We just copy it, click it on this scan body and fill. That's it. And it does it beautifully in about 10-15 minutes, okay? So where can you learn all this? Diploma in Advanced Implant Dentistry is part of the PAD Academy. Okay, so I will just run you through what we have done in the past few months to improve this, and this gives you a registrable qualification as well. Okay, so the 6 units of the diploma is Introduction and Assessment, Advanced General Practice, Dental Implant Surgery, Implant Prosthodontics, the Art and Science of Hard and Soft Tissue Manipulation, which is very, very important, and I feel that's one of the most important modules. And Unit 6 is very important because, as we all know, we see lots of failures, lots of complications, and quite a lot of peri-implantitis cases as well. The Virtual Joe, which I've put down there, will be our training platform. So it's like a model, 3D printed with a CAD file. You will have DCM file, that's a DICOM file, an STL file as well at the same time. And then you will go through all these 6 units using that as a part of your training. So you will plan on that model, you will place implants on the same model, you will create a little defect and you augment it, and then you rectify the defect when you get to Unit 6. So we will take you through the entire implant journey on our course, on this course. Okay, so these are the 2 main parts. So one's the diploma and one's the certificate. Can you all hear me clearly? Because
Sure. Yeah.
I can see the video hanging up a bit. No?
Very clear. Very clear.
Oh, brilliant. Okay, so this is now broken down into 2 aspects. One is a diploma in Advanced Implant Dentistry, I was told that by Eduqual that it's the only course which gives you an advanced implant dentistry and certificate in implant dentistry for those of you who just want to restore or place very simple implants. So let's go through the syllabus of the diploma in advanced implant dentistry, and I'll tell you what's not included in the certificate. Okay.
This is, of course, on the website, isn't it, Pavan?
It is, yeah.
So,
Yeah, sure. Yeah. So you can see the website now. Can you see the website?
yes, we can see it. Yes, clearly. Yeah.
Okay, so this is the syllabus. So the unit 1 is introduction and assessment. Okay, so this will be run, all of our units will be conference type over 4 days. And the aim is by the end of those 4 days, you should know most things in relation to that unit. Okay, so we have applied anatomy, physiology. You can go to our website and have a detailed look at all this. Documentation, record keeping, patient assessment and treatment planning. So you even if you don't place an implant, you should be able to plan and predict a good outcome. Or if you get someone else to place the implants for you, you can make sure that they do it at a fairly decent level. Okay, and then we will run a live session by Deborah Hall. She was ex-BBC presenter, and she will speak on personal impact and enhanced communication skills. Okay, so she will help with how you can make an impact the first time you meet a patient and to recruit patients as well at the same time. Okay, so unit 2 is mainly online. So advanced general practice unit. So I personally feel it's very, very important for you to have all these general practice skills to be a good implant dentist. So we've put all that together. Interactive critical reading will be a part of this. And our very famous Dr. Thomas Kos will be doing that for us. And standards in dentistry. So we will work on FGDP standards and maybe vary them a little bit when we talk about standards. So this, I'm talking about stabilization of the patient before we place implants. Applied occlusion, we'll have 2 full days, 14 hours, and it'll be Dr. Raja Ryan, who was the ex-dean of the Royal College of Surgeons. One thing I forgot to tell you about introduction and assessment is Jimmy Maktise's course, 2-day course, level 1 and level 2 training for CBCT reporting will be part of this course. Okay, and then we will run through dental morphology and anatomy for those of you who are interested in designing your own crowns. So we will make sure that you make it in 3D using wax or a draw. Now we have advanced softwares where we can design as well to practice. Then we'll have webinars on 3D scanning, 3D design, milling, and printing. Green dentistry is what I love to do, single teeth to full arch without models. Okay, so this will be the general dental practice module. The third module is implant surgery. Implant surgery, asepsis is a big part in implant surgery. So we do spend a day on that. And then we'll obviously discuss about various implant systems, and we will help you choose and pick the right one. Implant abutment connections are very, very important. So we will look into that in great detail. And then incisions, flap designs, and the various things which are very, very, very important, including suturing, soft tissue grafts, and all that. You can go into our website and have a look at that. We will make sure that you design a surgical guide at this stage, and I will print them for you. And we will get you to place implants using a surgical guide on one of our practice days. Okay. So all these modules are run over 4 face-to-face sessions supported by webinars. So implant prosthodontics is the 4th module, where we cover digital and conventional impressions, both open and closed trays, all types of scan bodies and flags, direct abutment scans, impressions at first stage, like what I just showed you. Provisionals are very, very, very important, as you know, to get a good emergence profile, to get feedback from the patient. So we will kind of train you how to do these things. Okay, fixed restorations, single teeth to full arches, cement retain to screw retain, and conical retention as well. Removable prostheses, timescales and protocols will be discussed in great detail. Advanced digital protocols will also be explained, and we'll show you how you do these full arch in a day and tooth in an hour and that kind of thing. We will arrange for live cases for you to come and watch us, and at least 2 definitely before you finish the course, but we aim to do more. Okay. And again, green implant dentistry without modules. Without models. Module 5 is augmentation, hard and soft tissue manipulation. Very, very, very important again. So we'll spend a day on biomaterials, bone expansion, condensation. The reason it's so important is 75% of my cases, most of them referred, will require one of these things. Will either require a small amount of biomaterials or ridge expansion or condensation or a localized onlay graft or a sinus lift. Okay, a sinus flow manipulation is very, very common, as you know. Inferior alveolar nerve lateralization, we will have a session on that as well, and a practical session, and periodontal plastic surgery, which is very, very important, as I said earlier. And these things can be applied onto teeth as well. It's not just on implants. Okay. And the 6th module, and the final module, is diagnosis and treatment of peri-implantitis and corrective surgeries, both hard and soft tissues, and corrections when an abutment's broken or an implant's fractured. And you really need to know that, because various studies have shown between 10 to 40% failure or peri-implantitis in about 10 years' time. So we really need to know. But if I've practiced this for 15 years. If you obviously learn from the right people, I definitely don't think your failures will be that high. Okay. And university, and there is a module on digital implant dentistry, but for the first few cohorts, we have merged it with the other 5 cohorts just to make things easier with the flow. So it'll all this in here is part of your training program. University of Tübingen has been an institute which has really, they've been part of designing 2 or 3 implant systems in the past. I went there about 14 years ago, and they were constructing full arches with spark erosion technology. They're always kind of forward thinking and a brilliant group of people. So if most of you on the course would like to go, then we will continue this module as well. But it depends on if they want to do it as well, because if there is keen interest, we will keep that going as well. So for those of you who join the certificate program, you won't have Unit 5, which is augmentation and complications. And in prosthodontics, we won't be covering full arch restorations and advanced immediate placements in full arch cases on the day and things like that. Apart from that, everything else will be covered, okay, the diploma and the certificate. So the fees for the course is £18,000. So we, for those of you who want to do the diploma with recognition of prior learning, if you've already experienced, if you've done other courses, we will definitely take that into consideration, and we will drop the number of days you'll need to come in order to gain the diploma, and your course fees also goes down. Okay, we can speak about that in greater detail whenever you would like to chat to us about. Okay, so let's go back now. Can you see this page now? The PowerPoint, yeah? Lovely. So you can't see the PowerPoint?
No. I think I can see your, is it your screen? Yeah, okay.
Yeah?
Yeah, we can see it.
So this is our core faculty. So let me introduce all of these for extremely high achievers. On my right-hand side is Dr. Carrie Bopanna. Carrie, today, funny enough, is Carrie's 50th birthday. So we're launching the course on his birthday. So he is a phenomenal surgeon, very helpful chap, and such a nice guy. And Carrie has worked as a maxillofacial surgeon and in Tata Cancer Hospital for a couple of years as well. 10 years as a max-fac surgeon before he got into mainstream dentistry. So he practices at a very high level, and I think we will make sure that is quite actively involved with module 5, that's augmentation, bone grafts, and incisions, and principles of wound healing, and that kind of stuff. Naresh, as you know, doesn't need any introduction at all. He was the chairman of the Board of Examiners at the Royal College of Surgeons when I did my MFGDP, I think 99 or 2000 or okay, back then. And Naresh has done that for such a long time. And he was instrumental in, along with Ashok, to put the guidelines for safe practice of implant dentistry in the UK, which was later adopted by the GDC. Ashok, you can correct me if I'm wrong there. And okay, and Thomas is an extremely talented dentist, and Dr. Kos has been my mentor and my teacher as well at the Royal College. He is like a walking, talking library. He knows every paper or a good paper written in implant dentistry. He is the co-author of Ashok's best-selling book, Practical Implant Dentistry. And he will really help us with what papers to pick with regards to thrashing papers and picking the right ones. Okay. And Ashok, as you all know, needs no introduction. He started implant dentistry about 42 years ago. He has followed up his cases for very long periods, about 35, 40, 42 years. And he sees that first case as well. And it is such a great honor to have Ashok here. And I think we really need to tap into that and get Ashok's experience on. So now I'll pass it on to Ashok, and then we'll get back to this final slide as to why implant diploma with PAD. So Ashok, it's over to you.
Okay, thank you very much, Pavan. That's very kind of you. So lovely. If I can. So my greatest advantage is age. And I just want to, let's see where I can, if I can start this. Okay, good, lovely. Thank you, Pavan, for such a wonderful introduction into the course. And before I even start this, I just want to tell you something about Pavan. Pavan is a brilliant clinician. He has shown you a lot of digital stuff. And what you don't remember, what you don't know about him is that he is a very fine clinician with a very good sense of being able to treat patients. I will tell you a little story. When we were teaching in Leeds, one day he came up to me with an X-ray and he said to me, he says, "What shall I do?" So I turned around to him and I said, "Well, this needs a bone graft. You need to get it from somewhere in the mouth. And at the same time, simultaneously, in this area, towards the posterior maxilla, he needs a sinus left dispersion. So I said to him, I said, you've got to work, have you done any implants? He said, no. And so I said, well, you've got to work with your tutor on this. Make sure that your tutor helps you or is there. A couple of months later, we're going through the course again. And he turns up and he shows me this x-ray and some photographs. And these are beautifully done, perfectly done cases, a lovely bone graft, well adapted, beautiful sinus lift, no tears. And I said to him, oh, wonderful, well done. Who helped you? And in the very Indian way they shake their head, he turned out and said, I did it on my own. So
it is you, Ashok. It's your teacher.
He's a very talented individual, and I think that is very important. The aim of this course, of the academy actually, is to train you. And what we want you to be able to do is to carry out whatever treatment that you do very safely. It's got to be effective. In other words, whatever you plan to do, you've got to have an outcome that's the one you wanted. And it's got to be predictable, completely predictable. And because we're dealing with treatment of patients, and therefore we need to be sure that the outcome is what we planned. I throw this up. This is an old slide from Kevin Lewis. And what you can see here is the litigation, the cases that came in for litigation to dental protection. Look at the orange piece, and that's a very large bit, and that's perio. Perio means that all patients get perio. And if that is that much litigation around perio, that's huge. Look at the pink section. The pink section is implants, okay? And that means a relatively few number of people who have implants result in having to sue dentists, and that's a huge shame because that's a very large percentage of the total population that we're dealing with. So what we are hoping to do here is we want to base our training on your needs, on the participants' needs. So if you are a beginner, we want you to start off simply, and we want you to avoid any failures and the consequences which Pavan has referred to. We follow the training standards in implant dentistry. That's my good friend and colleague, Naresh Sharma. He is the chairman of the FGD committee, which set up the training centers and training standards in implant dentistry. This group included all the stakeholders. So it included the universities, the ADI, etc. So it was a combined group that published this document, which has now been adopted by the General Dental Council. And so it is something that we have adopted, and it is something that we use. All surgery requires apprenticeship. In other words, we need to be able to carry out treatment with guidance from somebody who's done it before. And I think this is how we learn. In this day and age, it's called mentoring. But if you look at any surgical specialty, that's how it works. And so that's very close to our hearts. And that's something that we need to be able to provide for you, because that's how we feel that you will be successful. So our course structure is, Pavan has already mentioned it, and I'll just summarize this. We're going to have interactive seminars, that's face-to-face. There'll be, of course, webinars as well. And this is the core knowledge that you get, the details about how to do things. We need to have practical skills, and we need to therefore, as you develop your practical skills, depending on whatever level you're at, we will get you to do some work on some models. And when you do work on a model, you develop your skills to be able to go ahead onto a patient and carry that out. And as you know, Pavan is an ingenious person, and he's developed these amazing digital ways of doing these things. We will have treatment planning sessions so that you can plan your treatment for that, and that's a part of the assignment for the diploma course. And we will do some clinical treatment, And clinical treatment is a fundamental part of the course. That has already said that. A friend of mine, a colleague, Carl Misch, made this statement, and I remember this. And he said that for each failure that you need to put right, so let's say if you have an implant and you fail, you will lose the profit from the next 5 cases. That's a terrible financial burden that you will suffer. So it's something that should encourage us to make absolutely sure that we minimize the risk of failure. We want you to work within your comfort zone, but we also want you to expand, learn, expand, improve your skills, and develop yourselves further. So that is the essence of what we are all about. We need you to know your patient, okay? That is the best way to avoid litigation. When you come and you start this course, bring your patients you know, to have treatment, because you need to know their mind, the way they're thinking, okay? And you need to know also little things like how fussy they are and what they display. If they display their teeth and the gums and they have a broad smile line, those are difficult cases. And so those are the cases that you need to be very careful about. And that's why you need to know your patients. So if you're looking at managing something in the front of the mouth, in the aesthetic zone, it's perfectly okay to carry out treatment in stages. Everybody's in a hurry to just put something in, bring it into function straight away. But it's worthwhile sometimes just to do it in stages so that you can go ahead and you can place your implant in a predictable way into the site that you've selected, which you invariably will have planned on with 3D imaging, okay? You can then, 3 months later, come back in, take your selected abutment, and this abutment may well have been designed by your technician, or it may well have been designed by yourself on one of the digital formats, and you attach it at the time you carry out the exposure through this very small incision here. Once the abutment is attached, then you have a pre-formed temporary crown, which you insert into the mouth. This temporary crown will now form the emergence profile that Pavan referred to earlier. And it is this emergence profile that is essential for, and that's what is the pink aesthetics, and that is essential for the definitive restoration that you see here. So this gives you, doing the treatment in stages, gives you a chance to observe what you've done, make sure that the contours that you've got are correct at the time when you place the implant, so that when you come to exposing it, then you are sure of the direction you're going in. So staging implants is very important. And these principles, these basic principles, can be applied to more complex cases. So when you're dealing with multiple teeth, which Pavan does so expertly, and you get a case like this, you need to be able to think in terms of how you're going to treat this patient. So take this patient, the teeth are in the wrong place, they're odd colors. And if you want to convert it into something like this, what you do need to have is a process. You need to have a structured process of each stage, how to go through each stage so that you go to the next stage and you verifying as you go along what you're doing. And that's very important with respect to your own self-confidence. We all know that as soon as you take a tooth out, a certain amount of loss of hard and soft tissues takes place. This is inevitable. We need to know the bone biotypes of our patients so that we can predict how much bone loss will take place. That's very important. But invariably, some bone loss will take place. So we need to have a strategy for this. One of the strategies is to prevent bone loss. And you can prevent bone loss by placing an implant immediately, so maintain the tissue. So you can see the preoperative image on the left-hand side and the postoperative, the definitive crown on the right-hand side. And this has been done immediately. So we've preserved our tissues. However, if tissue loss does take place, then you need to know how to repair or replace the tissues that have been lost. And of course, that requires augmentation. So If you're preventing tissue loss, we would use immediate placement and loading. And of course, you've got to meet certain conditions with respect to that. So we have here a patient with a fractured tooth, which needs to be taken out. Now, so the secret here is actually you maintain the socket intact so that healing will take place. This is very straightforward. Whenever you take out a tooth, there's an extraction socket, and that will fill up with bone. We know that. But we need to make sure that we preserve the socket. And towards that end, I will show you how we can do that in a way. All your treatment, without a doubt, needs to be done, in my opinion, with 3D planning. There's no question of it. The human body is three-dimensional. You need to be able to see those 3 dimensions, and you need to be able to place the implant in the appropriate place. So, as I said earlier, you need to preserve that socket. So there are gadgets available, and this is the Benex extractor. It's a simple matter of drilling a hole in the root, that patient we saw just now, and you had nothing to get hold of to get that tooth out. And you don't want to lean on this soft tissues and the hard tissues on either side. Otherwise, you will damage those and you will get a compromised result. So this little screw, as you screw it into the root, and you take a ratchet and a little wire, and you just pull the tooth out, okay? And that way you retain the entire structure of the tooth. You can see the tooth has been removed, and it's just been pulled out by this wire that we see. Once we've done that, we've done our planning, and in accordance with our planning, and I think it's important to be able to develop some surgical skills first before you start to use digital dentistry. And you know that Pavan has these. And so then you can plan your treatment, and then you can see this being done freehand. And so it's a matter of just going ahead and creating your osteotomy as you planned with your digital planning. Then you can go ahead, once you've got your osteotomy, you can insert your implant into that site to the correct depth, because you need to know how deep it is so that you can have select the correct abutment. The abutment has been selected already on the digital plan, and then we insert our abutment into place. And of course, also either digitally or otherwise, we have our temporary ready. We call them transitional restorations, and we fit those, and so we end up with this sort of result that you see here that's directly on that day. Very predictable, but it does need a little more skill than just a staged treatment. If you look at the X-ray on the right-hand side, you will see there's a gap here. And this is a gap that exists whenever you take a tooth out. There is no biomaterials in there. And you will find that the body will fill that hole up with bone, and the bone will grow onto the implant and above the implant. And I will talk to you a little bit more about that later. Our problem is the high lip line. If you have patients like this, they often can't go around like that, rightly so, because they show all this, and they often go around with a little pink veneer and a partial denture to cover the long tooth that's visible there. So we've got to be able to repair both the hard and soft tissues, and this is certainly something we will be addressing. We will show you how to do this. You can see here, this is the failing tooth that we looked at. You can see the pathology associated with that. And what we've got to be able to do is to provide the patient with a provisional restoration whilst treatment is going on. And this is a bridge, and you can see here that there's a very large deficiency above the tooth itself. Putting an implant in here would not be satisfactory for this particular patient. So you have to correct that deficiency that's there. And this is done here in this case with a block bone graft. Look at the image on the top left-hand side. You can see it's nice and shiny. That's just been harvested from the chin in this case. And if you look at the image on the bottom left-hand side, what you see is something quite remarkable. And that is that 3 months later, what you see is that bone graft itself is bleeding. So it's picked up the blood supply and it's integrated. The image on the right-hand side now, this is why stage treatment is so important, is telling you that you're heading in the right direction. So you've got this temporary crown, the same one that you saw earlier. Now look how short it is, okay? So we've got the amount of tissue that we need to be able to provide this patient with a good, predictable restoration. And believe it or not, bone grafts can be very predictable. What we're looking at here is you can calculate the number of years, a period where it's been completely stable. The soft tissues are stable, the bone is stable, and we need to be very careful when a person has a high smile line, because if you're not careful, it is not forgiving. If you walk around with somebody smiles at you and that's what you see, then you should be sued. I shouldn't say that, but you will be sued, because this is an issue that could have been avoided by proper treatment planning and proper surgery. So we will take you through, we will show you basically how to safely harvest bone from either the chin or the ramus, depending on the situation. We will show you how to shape it and secure it into place with or without the use of any membranes. And that is, by the way, the best biomaterial there is, autogenous bone. And just, there are no shortcuts in this. You know, we have to do this properly. I think there's a lot of information out there about short implants, and short implants do work. There's no question of it. But I think we shouldn't push the boat out too far. So you can see on this CT scan here, on the arrow on the left-hand side, you can see the horizontal arrow, and you see the implants that have been placed on the patient's right-hand side. Okay, these are sticking into the sinus. You can see the same on the image on the right-hand side. This is a cross-sectional image, and you can see how the implants are in the sinus itself. And you can also see the pathology associated with them. But what is most interesting is the image on the left-hand side with the vertical arrow. And in that, what you see is a hole, an oroantral so-called fistula, where the implants that were placed there failed and they had to be taken out. And this is because somebody was pushing the technique too far. Short implants are okay, but I think in many ways they are more difficult to do because they're less strong. So do it correctly the first time round. Otherwise, there's, as Mish said, there's the next 5 cases you will do for free, so to say. So now, the reason I showed you that case is that this person obviously didn't learn to do a sinus lift, and they thought they could get away by just manipulating the sinus flow in some way. You need a certain amount of space before you do that. But let me explain to you what a sinus lift is, okay? There's, on the image that you see, it's a cross-sectional image of a sinus, which is enlarged considerably, okay? What is that? Well, that's a hole in the bone. You take out a tooth, you know what happens. You take out a tooth, it'll fill, that hole will fill up with bone, maybe not to the same dimension, but it will always fill up with bone. Otherwise, the patient isn't alive. Here, this is a hole in the bone, but it's not full of bone. And the reason for that is that there's a lining there. And you can just see the lining in this image here. Now, if you imagine lifting this lining up, it would fill out with the blood clot, and then the bone will fill that gap. And a very clever man called Stefan Lundgren tried that. He just put the implant in, propped it up with just the implant, and he found that bone formed around the implant. So this has been published. But what we do is we try to use a biomaterial to hold that, the membrane up. So it's really a question of now creating a hole in the lateral wall of the maxilla, going in with a variety of instruments and lifting that sinus. And the movement of that sinus window that we've seen shows you that there's no tears. Because if you have tears, you have a high risk of infection, you have a high risk of implant loss. So we need to make sure there are no tears. And then, of course, carefully. You need to put in your biomaterial. You can see how it's been isolated by gauze, and you need to just put this in and put it into the floor of the siding. So you don't need to now push it upwards or tear the sinus lining, just put it into the floor of the sinus. So now what we've really done is we've created a hole in the bone, and we've provided support for the sinus lining, which will stay up, so that we can come back in a few months' time and see the amount of bone that has been developed in this case, and we can plan our implants, and we will have secure solid implants. Pavan mentioned the issue with peri-implantitis that is taking place. So we will want you, and you will want to, develop a maintenance and monitoring protocol. You want to avoid peri-implantitis. And here you see a probing depth of 15 millimeters. On the right-hand side, you see the amount of bone loss that has taken place. And so you need to now make a decision whether you want to try to save these teeth or not. So if you're going to save them, then there's ways in which, I'll just turn that down a bit. There's ways in which you can clean the implant surface so that soft tissue certainly will reattach to that. Alternatively, you have to make a decision, and this is a decision that you need to decide with the patient as to whether we want to retreat, whether you want to remove these implants and then correct that deficiency with a bone graft. If you do that, then you want to also be sure to reduce, I can't say eliminate the risk of future peri-implant disease, but you need to reduce it. And towards that end, we'll have a session on implant selection. And what you see here is 10 years ago, when we did this, you can see the implants on the X-ray. You can see the soft tissues in the image on the bottom left. And you can see that the bone has actually grown over the implants. Okay, this is actually the grafted bone. What is interesting to see is the next image here. You see the soft tissue stability is there. And most importantly, what you see is the bone level is still there. This is 10 years on. So the bone levels are stable. There is no interest, there's no recurrence of that peri-implantitis that we saw earlier. And I think it depends very much on the very tight connection that we have between the implant and the abutment. These are ankylosing implants, but we use something called MyPlant 2, which we will introduce you to, along with other systems, so that you can choose for yourself as to what priorities you want. The most important part of the treatment is the restorative treatment. Cement retained restorations are very straightforward. They are very convenient. We know, our technicians know what we're doing. We know what we're doing. We just take a standard impression of an abutment as we do for a tooth, and we make a tooth and we cement it into place, making sure that there's no excess cement. And so we can do that very easily. Screw retention, when you think in terms of screw retention, you're using different technology, okay? And if you're going to do screw retention, there's no doubt in my mind that you need to move into CAD/CAM technology, because that's what enables you to produce something that is accurately fitting, okay? Just want to show you this image of this patient that came to see me. And this is screw retention carried out incompetently, if I may say so. And if you look at the implants, the zygoma implants that have been placed for this patient, you will notice that there are no screws there. There are no screws there because this prosthesis, this framework, did not fit. They couldn't even put the screws in. And if you look at the lower implants, you can see there is a whole lot of issues there as well. So CAD/CAM technology and an accurate impression. The most important thing is the accurate impression. Otherwise, you can't produce something. And this can be done conventionally or digitally. So that is the secret to it. As I said, cement retention is something we're familiar with. We have no screw access holes. We just cement the prosthesis in place. And in my view, we get very good outcomes from that. Finally, what is new in implant dentistry, and there's not many systems that are using it, there are a few that are, and that is conical retention. So if you look at this, there's an abutment. This is a MyPlant 2 abutment that you see here. You can see it's conical. And you can see next to it is a coping. This is pre-milled. So that means it's very accurately fitting. So if you remember at home, if you put two glasses together, they get stuck, the Morse taper principle. So if you put this abutment in the mouth and then you attach this cone onto it, it will stick, and it'll stick very firmly. And so you will get from your technician or wherever, I don't know whether we can, let me just see if I move this out of the way. Yeah. So you can see here a crown that has been prepared, and inside that crown, you see the actual conical abutment that you've seen. So when it comes, so you get your crown back from your technician, and then what we do is we put it in, and it just requires a little tap from this instrument, and it's secure. Very, very rare for these to come out, and they're secure. The most important part of this is the fact that if you look at the image on the left-hand side, there is no microgap. There are two potentials for microgaps. One is between the implant and the abutment, and the other is between the crown and the abutment. So now there's no microgap. You see on the image on the right, there are absolutely beautiful soft tissues, and Pavan has shown that already several times now. And we are now assured of a few things. One of the things that I'm assured of is there's a very low risk of this patient ever getting peri-implantitis, because the implant itself is protected by bone that has grown in. So that's the important thing. I showed you an image earlier, but here you can see how the bone grows in. So we want to avoid failure. We would like you to make sure that you don't have any failure, because that's a bad reflection on us if you do have failures. So what I would like to do is to thank you all for your attention, and thanks Pavan for his extraordinary presentation. And we would like to now have a discussion. And Pavan, we're going to do this by messenger, or are you going to open it up?
Yeah, so if they have any questions, you can type here in the chat box, or you can ask us a question. Turn on your video and your audio and ask us questions, please, whatever you feel comfortable. Yeah.
If you have no questions, then we will assume that we've been effective. But we should have needled you in some way or the other. Okay. Are there any questions coming? Do you know?
Not yet. No.
Sorry, maybe I'll stop sharing. Okay.
Yeah. Do you all want to turn on your audio and video, ask a question or ask a few questions, or there are no questions at all?
Hi, Pavan.
Aman?
Pavan, could you just go a bit more over how the learning in regards to perio? Because I'm really interested in the free gingival grafts and the connective tissue grafts. And will there be some sort of a like a pig's head or something like that where we could carry these procedures out, or is it mostly a learning-based thing rather than practical?
Shall I answer that?
Yeah, go for it. Sure.
So we have developed models. It's normally a pig, believe it or not. Both the maxilla and the mandible, where we would cover, where you practice. As I said to you earlier, we have a lot of practical sessions, and during these practical sessions, what you do is you develop your skills. So we will certainly be covering that. We will be covering about 4 or 5 different types of grafts as well, so that you become familiar with them. And then, of course, if you need to do that, and if you need somebody's guidance, and then Pavan is there. And Carrie is there to help you. Okay.
Brilliant. Thanks. Thank you.
Yeah. So the next question is from Pascal Pinto. He says a bit more on hands-on, please. So Pascal, we have pretty much 20 days face-to-face sessions, and most of these will be hands-on, training you on various things, from implant placements to impressions to connective tissue grafts, like Ashok just mentioned. So most stuff for skill development and practical sessions. Yeah, and secondly, in case you choose to have a mentor, it is always good to have a mentor. You could definitely get them to do it on patients, or you could do it on patients and they could watch you, depending on your level of experience. Yeah, Ashok, is there anything else?
No, that's it, isn't it? I mean, that's the essence of what we do. What we do is we go ahead and we practice something. If you've not done something before, you practice it. I mean, there are geniuses like Pavan who just you just tell them how to do it and they do it. And if you feel that way, then obviously that's what you do. But yes, you practice on a model, and you can, you'll do it on a number of occasions. And when you're comfortable with it, you can do it either on your own or with somebody just guiding you.
Yeah.
So that's the way to develop your skills.
So Pascal Pinter's second question is, would there be an assessment at the end of each module or course? So as part of our qualification for the diploma, we have four assignments. So what we've done is all 4 assignments are 100% applicable for your general day-to-day practice. So the first assignment is writing a treatment plan letter to your patient. So if you get that out of the way, then it's half the problem solved. So you're informing the patient really well as to what the procedure will entail and how you do it and all that bit. So the second one is choosing an implant system. So you've got to be able to justify why you chose what you chose. So that is the second assignment. Third is implant abutment connections and its bearing on aesthetics and function as well. So, and the fourth one is peri-implantitis and complications. So all 4 we thought are very relevant topics and very, very important. So these are the 4 assignments we'll have. Okay. And in between those, for 100 hours of webinars, which we have planned, and these 20 face-to-face sessions, we'll have some MCQs, just to make sure that, you're kind of up to date and reading up what you're asked to read. Okay. So, and there are 5 cases to be presented. We'll make it very, very, very simple. It's not complicated, and accessing tutors or help or access from us will be very easy. So 5 cases for the diploma will be one single implant anywhere, 1 aesthetic zone, 1 small graft, GBR, or block bone graft, whatever you prefer. A very small case, 1 multiple splinted, and 1 any of the above. We would ideally want to show you the digital workflow. So at least 1 case of the 5, it would be nice if you could do it digitally. It's not a must though. And for certificate, patients course participants who are planning to do the certificate, I know that they're not very serious about implant dentistry, or they're serious only about restoring implants. So they just need 3 cases, 1 simple placement, and 1 aesthetic zone, and 1 any of the above. Yeah. Does that, so that's good. So where are the face-to-face lectures held? Yeah, so it's as of now we've pretty much confirmed it will be in Sheraton near Heathrow. because we thought the rooms are very spacious. We can get all the course participants a pretty good deal there as well. And it's easy to get there for people who are flying from other cities, and for those who drive just off the M25 and get to Heathrow, so you can drive as well. So we have dropped the idea of a central London location, and we chose Heathrow, Sheraton. Where are the face-to-face lectures? Yeah, it's the same question. Do you have the dates for face-to-face lectures for the September 2021 intake? Yes, we do have the dates. Yeah. So if you write to Sally, contact at pad-academy.co.uk. Sally will respond to you with the dates. Okay. So it's September, December, the following March, June, September, and the following December, you'll be done with the diploma.
It's the 8th to the 11th of September that we've chosen. Just needs confirmation with the venues, that's all. So if there's any change, we'll let you know what the precise dates are, but those are the ones we've gone for the moment. Is that helpful?
Yeah, absolutely.
And this question from Alan Howie is just for you.
Yeah. So Alan, my personal choice is trios, 3-shape, but I can explain why. Maybe, if you contact me directly, I can explain why that. I've used many other scanners, as I showed in the presentation before, but my personal choice is trios, 3x3 shape. Yeah. Perfect. Any other questions at all?
Good.
Oh, brilliant. There's a thumbs up there. Yeah.
Fantastic. Well,
fantastic. So thanks a lot, Ashok. Thank you.
Well, thank you, everybody, for attending.
Thanks, everyone.
Very nice. It's good of you to give up your Thursday evening. We know you could be doing lots of other much more interesting things, but there you are. Thank you, and hopefully those of you who are interested will join us over the next 18 months or so, and we will make every effort to make sure that your needs are met, whatever they are. Okay.